Hey YouTube, welcome back to my channel. My name is Dr. Daniel Kaplan and my mission is to make psychology accessible to all. In today's video, we're going to talk about the DSM-5, and the DSM-5 is the manual that is used especially in the United States for diagnosis and classification purposes. We're going to explain what we mean by the word classification. We're going to talk about the DSM-5 and some of its strengths. We're also going to talk about categories versus spectrums, which is something really cool in the DSM-5. And then we're going to evaluate the DSM-5 as a whole. Without further ado, let's get into it. As I mentioned in the intro, we're going to start by explaining what we mean by classification. So classification refers to a system that we use to represent major categories of childhood psychopathology or dimensions of childhood psychopathology. And we use strategies to figure out what the best plan is given what's going on with an individual. Now, the two strategies, and I talked about these strategies in other videos, are idiographic strategies and nomothetic strategies. When we think of idiographic strategies, we're highlighting the uniqueness of the child and the environment that the child is in, whereas a nomothetic approach is we're trying to use an existing system or for classification and diagnosis purposes. And in nomothetic strategy, we look at group norms or what is expected for an individual relative to their age group and so forth. So yeah, that's a classification system. Now, developing a system like this that is simple and concise is very important, but it is very hard to do. And in fact, we are now in what's called the DSM-5 text revision, meaning that we've had 4 attempts prior that needed to be modified and further developed. So the fact that we have a DSM-5 means we had a 4, 3, 2 in an original one, and we will have a DSM-6, right? Because the science of psychopathology is constantly evolving, and we want to make sure that it is an appropriate representation of the science and the diagnoses are appropriate. So when we talk about categorical classification systems, usually it's based on consensus of professionals, and there is an understanding that each diagnosis has a clear underlying cause. I would argue that there are many causes or origins of mental illness. So we talk about etiology. And when we use a categorical classification, there's an understanding that each disorder is fundamentally different from the others. And as we will learn in the DSM when we go through the conditions, there is something called a rule-out diagnosis. So when we're coming to a categorical classification, we're going to have to make sure that the person has disorder X, not Y, not Z, and so forth. So there are unique features to each disorder that would allow them to stand alone. So that's the categorical classification. When we talk about dimensional classifications, now things are on a spectrum, and we're looking at the extent to which a child possesses a given behavior or dimension. And it can vary from degree to degree. And we do look at externalizing and internalizing behaviors as dimensions, and those are examples. So if we were to look at dimensions of childhood psychopathology, there's a whole host of dimensions. When we talk about anxiety, the degree to which a person cries will differ from person to person. worry and so forth, also the same thing. Somatic, right? So headaches and aches and dizziness and aggression and so forth. We could go through all of these types of dimensions, but I just want you to see within larger domains some of the sub facets that we see, and they do go on a spectrum. Okay. Now, the DSM-5 was published in 2013, and it was meant to be a significant update from its predecessor, the DSM-4, right? And we see that there's roughly 2 decades of research that informs the change. And our knowledge base regarding child and adolescent behavior and diagnoses has shifted. And I'll give you an example. In the DSM-4, we had different diagnoses for childhood disintegrative disorder, pervasive developmental disorder, and autistic disorder, and so forth. But what we understand is that these conditions they share a lot of properties. So instead of having distinct categorical diagnoses, we have autistic spectrum disorders, or ASDs, which absorbs the various conditions related to it into one diagnosis. And then we specify a little bit better, what's going on. So our understanding of autism has shifted so markedly that we needed to change how we even approach autistic spectrum disorders. So that's a big example. Now, in 2022, we also had what's called the text revision. Now, text revisions are designed to further clarify what was going on with the diagnosis. If there is a typo, you fix typos and so forth. But here are some of the highlights of the changes in the DSM-5 text revision that just came out. One, there is a new diagnosis called prolonged grief disorder that allows for a person who's struggling with grief and loss to extend beyond a year. We also see that there is a clarification on more than 70 different disorders. We also try to merge the ICD symptom codes with the DSM. Now, the ICD is the International Classification of Disorders. I said the DSM is the predominant manual used in the United States. It is created by the American Psychiatric Association, but other parts of the world rely more on the ICD. So trying to fuse the two so that there is more uniformity between international manuals and the DSM was very, very important. Now, we also see that there have been extensive literature reviews and added resources and citations for most of the diagnoses. And we also have tried to put an emphasis on racism, discrimination, cross-cultural factors that could impact the prevalence and features of a given diagnosis or mental disorder. Now, the DSM-5 has many different conditions of interest. We're going to talk about neurodevelopmental disorders, and the common ones are intellectual developmental disorder or an intellectual disability. It used to be called mental retardation, so there's a big shift there. We talk about autism spectrum disorder, or ASDs, communication-based disorders, learning disorders, ADHD, and motor disorders. So there are specific conditions that apply to children and adolescents, but there are also other diagnoses that are more general and occur across the lifespan. Things like a major depressive disorder that can occur in childhood and adolescence, but it's not specifically or directly related to a childhood condition. So we also have specifiers. So the DSM-5 uses specifiers to further clarify what's going on. It allows for us to communicate information that's relevant to the treatment of the disorder. There might be subtypes of the disorder. We might want to rate the severity of a condition and note any kind of general medical conditions that play a role. So the specifiers were designed to address some of the things that might have been in the multi-axial system in the DSM-4. Now, I'll give you an example. If a person has ADHD, attention deficit hyperactivity disorder, we can't just state ADHD because there are 3 different subtypes, right? So there is the inattentive subtype, there is the hyperactive subtype, and the combined subtype. So when we use specifiers, it further elucidates what that diagnosis is. So if I say ADHD inattentive subtype, now I know that they're predominantly have distractibility, they might make careless mistakes on their work, they might start tasks and not finish them, and so forth. So I understand the features of an inattentive subtype, whereas if it's ADHD hyperactive subtype, I'm looking for more of the impulse control related conditions, like having an inability to wait one's turn or stay in one's seat, blurting out answers, things like that. So the specifier inattentive subtype versus hyperactive subtype, it gives further information. Another example, major depressive disorder. Well, major depressive disorder has different features. So if it's related to seasonal onset, right? So you might have heard seasonal affective disorder or the winter blues or the summer blues. We would say major depressive disorder with seasonal onset. That's a specifier. Now, we might also specify severity from mild, moderate, severe, and so forth. So we, in addition to the subtype of the condition, we can specify severity. There are other considerations we have to be mindful. We also have to consider the psychosocial and environmental concerns that affect diagnoses, things like negative life events. A negative life event might be parental divorce, might be moving from one town to another. There could be deficiencies in the environment, familial stress, lack of social support, and so forth. These contextual factors are very, very important in understanding a child's, behavior and their emotional mindset. So we have to be mindful of that. But the DSM-5 has moved us along in a significant way, and there is the DSM-4 and 5 did a greater job focusing on things like culture, but it's not without criticism. In fact, there are some people who believe aspects of the DSM-4 were better than the current edition. But here are some criticisms. One is that the DSM-5 fails to capture adaptation, transactions, settings that impact the understanding and the treatment of childhood psychopathology. It also doesn't do sufficient emphasis on situational or contextual factors. We also see there's limited information on disorders in infancy and childhood, and the interrelationship between various childhood disorders, there's not enough emphasis. Now, every single DSM is a manual in progress, is a work in progress. So these criticisms are important for the think tank who's working on the DSM-6 to take seriously. And every single manual is going to have its criticisms. So if I were on that task force or think tank developing the DSM-6, I would spend time saying, well, what were the clinicians and consumer groups' biggest criticisms? And taking these into consideration is very, very important, right? So it also, a criticism is that there are a large number of diagnostic categories that have limited validity, and the strong focus on classification is directly observable behavior. But the problem is that we need to focus on underlying biology of the behavior or aspects of functioning. So there is this research domain criteria that is trying to shift how we conceptualize disorders. So pros and cons, right? So when we talk about a diagnosis, some people might have a knee-jerk reaction to the stigma around the diagnosis. But there are some benefits to having a diagnosis, right? So first and foremost, it allows us to summarize our observations as a clinician. It also allows, if there is communication between various clinicians or a treatment team, using a diagnosis gives a set of assumptions, and it's a framework. So it facilitates shared communication among professionals. Now, some of the cons of diagnostic labels is there is a debate whether the use of diagnoses or labels achieves their purposes, right? There is a stigmatization, which we've talked about. People don't want to be viewed as a label. And then obviously there is the possibility of an internalization of a label, which can alter how children view themselves. Now, one thing I will say as a clinician, I will speak to any of my clients about what diagnoses they have, but not every client asks me, okay, well, what's my diagnosis? And to the extent that a client doesn't ask, I find it more useful to focus on the behavioral deficits or the emotional deficits or the thought disturbance, focusing on that, the symptoms of the diagnosis rather than the label itself. So I will spend more time talking about the symptomology versus the label itself, because I know the stigmatization, I know the internalization of mental health problems. We have to be very careful. Now, just to give you an example, we have moved significantly in the right direction. And you'll see the DSM-1 and the DSM-2 were heavily influenced by psychoanalytic thought. The DSM-3, in an attempt to be more research-based, and the DSM-4, in an attempt to be more research-based, shifted away from the psychoanalytic mindset exclusively and moved towards a more broader biopsychosocial approach. What's nice about the DSM-5 is it does put a stronger emphasis on biology and underlying biological factors. And you'll see at the end in 2022, we have the RDOC, which is the research domains of concern. We're not sure where that will take us. I think that will take us forward in terms of our scientific understanding of mental illness, especially when it comes to child and adolescent disorders. So I'm going to stop there. I hope you found this video useful. It really takes you on a journey as to what the DSM-5 is attempting to do. As I said, there are two different approaches to the DSM-5. Some conditions we use categorical distinctions, and other conditions it's more dimensional or spectrum based. That's one of the better understandings. We talked about specifiers and the role of specifiers in further clarifying a condition. And as I said, we evaluated the strengths and weaknesses of the DSM-5 with a look to the future of the RDOC. Once again, that's today's video. I hope you found it meaningful. If you did, hit the like button, subscribe, consider clicking the notifications tab. That will allow you to have further access to my other videos when I release one in the future. Also, if you could consider putting a comment in the comment section, anything that was a reaction to today's video or a question regarding today's video, feel free to use the comment section as a resource to further create a learning community. But that's today's video. And until next time, take care, everybody.